Okay, so let's move on away from the anatomy of skin, and we're going to talk about skin conditions. But first, we'll just discuss just how we categorize and how we use different terms to describe primary skin lesions. Okay, so a cyst is usually fluid filled. Okay, so for example, earlier I mentioned sebaceous cyst. Well, that would be a structure, a cystic structure that's filled with sebum. So any fluid-filled structure that's raised above the skin, we can call it cystic. Okay, a fissure is really just a crack in the skin. So whether it's the end of your fingers in the very dry winters, and you get fissures in your skin, or the corner of your lips, they sometimes get fissured in the dry weather. That's all it means. Just a crack. A macule is a completely flat lesion. So if you were to run your hand over a macule, you wouldn't be able to feel the difference between the macule and the normal skin. It's completely flat. Okay, a nodule. So a nodule is a lesion that's raised above the level of the skin. And what's the difference between a nodule and a papule? Papules are usually just smaller. Okay, so a nodule is usually greater than 1 centimeter around, and a papule is usually less than 1 centimeter around. So it's really just the size of it. Okay. A polyp, well, you can get polyps in your colon that we've spoken about before, and they can actually become cancerous. Well, you can get polyps on the skin, and they're typically not cancerous. So you can think of a polyp as having a little stalk that attaches it to the skin, and almost like a head to it, and it just hangs off the skin. So it's a description, right? So it's we can describe a lesion as having a polyp type appearance, or a papular appearance, or a macular appearance, just depending on what it looks like. A pustule is again, it's raised above the level of the skin, but it's pustular, meaning there's there's pus inside. Okay, or for example, a whitehead from acne. Well, that would be pustular, right? Because it would have pus within it. A vesicle, well, they're small, fluid-filled structures. So, for example, herpes zoster. Well, that's a vesicular rash. It's fluid-filled. So small little blister uh, type vesicles that if we were to cut one open, just clear fluid would leak out. Okay, herpes. So genital herpes or oral herpes, those are vesicular rashes as well. A wheal is typically when we're referring to an allergic reaction, right? So the wheal is the raised part, and it's typically has a bit of a pale appearance, and around it is a red area. So we call it a wheal and flare reaction, and that's typically a rash that occurs with an allergic reaction. Okay, so let's just quickly go around and I'll choose a condition based on um, the description that we can see in this image. So a cyst, I mentioned a sebaceous cyst. A fissure, I mentioned, say, a cracked corner of your skin or your lips, sorry, that are fissured. A macule, well, a macule is, say, a freckle, or a condition where you've lost pigmentation of your skin called vitiligo. Well, it's totally flat still, so it would still be called a macular rash. A nodule, well, a nodule can be associated with acne, so nodular acne. Okay, raised lesions above the skin. A papule, smaller lesions, so you can have papules with acne as well. A polyp, say a skin tag. So typically under the arms, we can get these little skin tags, sometimes at the neck. They're just extra little bits of skin, and they have a polyp appearance. A pustule, well, those are whiteheads typically. They'd be associated with, say, acne, or if you had an infection of the skin called folliculitis, which is an infection of the hair follicles, and it shows up as multiple white pustules all over the place, well, that would be a pustular rash. A vesicle, I mentioned herpes, or herpes simplex or herpes zoster. And finally, a wheal and flare, that would be an allergic reaction, such as an insect bite. Okay. Okay, so let's look at some examples again. So in dermatology, looking at examples and pictures are much easier than trying to describe them. So when we're talking about macular lesions, that's flat. So at the back of this person's throat, those are petechiae. Well, petechiae are totally flat, whether they're at the back of your throat or on your skin. Okay, so when you rub your hand over petechiae, you can't feel them. Okay, freckles, that's a macular rash. And certain moles, not all moles, but some moles, so nevi or mole is the same term. Some moles are macular, meaning they're completely flat on the skin. Other moles have a bit of a raised appearance to them, and of course we wouldn't call them macular. Okay, so here's some examples of papules on the left, right? So there's a skin condition called a papilloma. So it's raised above the level of the skin, and it's papular. Okay, just a description of it. A wart is a papule as well. Okay, a lesion that's raised above the level of the skin. If it gets to a size, typically we call them nodules. Okay, so papules and nodules are basically defined by the size. Vesicles, so vesicular rashes are fluid filled, and it's typically clear fluid. So herpes in the top right and chickenpox, or herpes zoster, those are all vesicular type rashes. Okay, so we didn't mention the word plaque yet, but you can probably imagine what a plaque is. So it's a larger area of raised tissue, and plaques are classic for psoriasis. And we'll talk about psoriasis on another slide. Okay, so if you look at this lesion, looks like it's the neck area. Hard to tell by just this little area, but that's a plaque. It's raised above the level of the skin. And on top of the plaque is this white silvery scale, which is classic for psoriasis. A wheal and flare is typically an allergic reaction. So you can see this raised central area, which is typically white, with redness around it. That's what we call wheal and flare. From allergies, insect bites, sometimes medications. Pustular rashes, I mentioned, they're filled with pus. So if you look at acne on the lower slides, or another condition on the lower right called folliculitis, well, that's pustular. Okay, so when we look at them, we can tell that they're filled with pus. They're not vesicular because they don't have clear fluid in them. Okay, and if you would actually look very closely at the bottom right image, you would see that there's a hair cell, there's a hair shaft coming out of each one of those. So that's folliculitis, infection of the hair follicles. Okay, let's just briefly talk about this condition, vitiligo. So this is the absence of melanin in the skin because of an autoimmune condition that destroys the melanocytes in a patchy distribution. So you can see on the arm below or on this person's face that there's absence of melanocytes and there's absence of melanin. Okay, so it's hypopigmented. And by the way, it's macular. It's flat, right? So, so macular is just a description of, is it flat or raised? That's it. So it doesn't tell us what the condition is, it's just a description of it. Okay? So this is an immune system, an autoimmune issue with destruction of melanocytes in different parts of the skin. Okay, and here's another pigment condition called albinism. So this one happens to be a genetic condition where people are lacking usual pigment of the skin. Okay, and often with albinism, there's pale skin, there's very fair white hair. Some of these patients can often have visual impairments um, with this condition. So, how is it inherited? Autosomal recessive inheritance. Okay, so these patients are very prone to skin cancers because of the lack of pigment. And I mentioned on a previous slide that pigment is very important to the skin to protect against UV radiation. Okay, so these patients often, as they get older, need ongoing skin assessments to make sure that they're not developing any precancerous or cancerous conditions, and as well, they need regular eye checkups. Okay, so what's xerosis? Well, that's just a term for dry skin. Okay, remember we like fancy terms, so could have just put dry skin there. But instead, the term is xerosis. What causes xerosis? Well, many things. So aging is extremely common. Over cleaning with soaps. So you're taking oils away from the skin when you're constantly washing your hands or constantly bathing. Okay, so children often come in with very dry skin because there's a lot of they're being washed frequently. They're in the bathtub potentially every day with bubble bath, which is a soap, and they get very dry skin. Okay, so basically just overwashing with soaps can lead to xerosis. Bathing too frequently, dehydration. So very dry winters, for example, will lead to xerosis. So cold weather typically means dry air. So patients get xerosis commonly in the winter. And it leads to this rough, scaly, dry skin. Okay, and then that leads to fissures, right? The skin starts to open in areas, and that puts people at risk for infections. Okay, and the treatment's pretty straightforward. It's usually daily moisturizers and frequently, right? And also making sure that you keep well hydrated because, of course, some of that fluid goes to the skin. Okay. Okay, so pruritus or pruritic skin, just another term for itchy skin. Okay, and it's not telling you what the problem is, it's just that the skin is itchy. So itchy skin can lead us to potentially many different disorders, but at least it narrows it down for us a bit when someone says, I have itchy skin. Okay, so it can be an issue with the skin itself, or it can be an internal issue. For example, liver failure. Uh, when your liver fails, you get bilirubin in your bloodstream, and bilirubin goes to the skin and become jaundiced. But bilirubin is very irritating to the skin. So patients with liver failure very frequently complain of itchy skin. Okay? And as well patients with kidney failure. Because of the toxins that are building up in the bloodstream, they also complain of itchy skin. And this is typically caused by histamines that are released by mast cells. Okay? And people get into this cycle of scratching more itching, scratching, more itching. Okay, so it's a bit of a cycle that needs to be broken, often with medications. Okay, so there's some examples below that are very itchy. So chickenpox, eczema that we'll talk about, um, which is a dry, scaly lesion of the skin. Scabies, which is an infestation of the skin, is incredibly itchy. Okay, and typically scabies is between the fingers, under the armpits, in the groin, um, and this infestation burrows under the skin um, to lay its eggs, and it's incredibly itchy. Okay, head lice, well, of course, that's going to cause scalp itchiness, which is another infestation. Contact dermatitis is a condition where you've come in contact with something that's irritated your skin, and it's resulted in a rash that's extremely itchy. Okay. Other examples, environmental causes, well, detergents, soaps, insect bites, anything that you're allergic to, say poison ivy, poison oak, anything like that can cause itchy skin. I mentioned the internal causes, renal failure and liver cirrhosis. Both lead to itchy skin. Okay, so let's go on and talk about acne, and the full term is acne vulgaris. Um, and this is inflammation of the pilosebaceous unit. So what's the pilosebaceous unit? Well, basically the pilosebaceous unit is made up of the hair follicle and the erector pili muscle and the sebaceous gland. Okay, and they're found in all regions of the skin except for the palm and the sole of the foot. Now, in particular, they're most dense on the scalp, the face, the neck, and the shoulders. Okay. Now, at puberty, what happens? So at puberty, there's androgens that are secreted, and the pilosebaceous unit matures and develops with androgens. So that's why acne typically begins with puberty. Okay, and what occurs is the sebaceous gland, which is typically almost invisible before puberty, become activated, uh, and they can become blocked. So the pilosebaceous unit can become blocked with sebum, and that sets up inflammation, right? So acne has both an inflammatory component and non-inflammatory lesions that we'll come to. Okay, in this image, you can see some pustules, those little white-filled raised lesions. There's some papules that, again, they're raised, but they're not pustular. Okay. Okay, so how does acne develop? So I mentioned it typically develops with the secretion of hormones at puberty or after puberty. Okay, and typically it's androgens, so the male hormone, that is most responsible for activating the pilosebaceous unit. Estrogens can also activate this pilosebaceous unit, just not to the same extent. Okay, so what happens is the hair follicles become plugged with dead skin cells and oil, and that causes inflammation behind the plugged follicles, and typically that results in what we call whiteheads and blackheads. So what are whiteheads? Well, those are typically the pustules, right? So the ones that you can see on someone's skin that are filled with a bit of pus, we call them whiteheads. What are What are blackheads? Well, blackheads are usually the it's the plugging in the pore that's become oxidized from the air and it's turned black. So it's just showing up as plugged pores that have now the tissue the little plugged pores have become oxidized, and they're now appearing black. What other primary skin lesions show up as acne? Well, they're papular, right? They're raised, so papules, pustules I mentioned, and they can even get to cysts. So severe acne that we'll talk about in a minute, you can get nodules, which are larger than papules, and cysts forming. Okay, that's typically in more severe acne. There's also a bacterial component to acne, and that's partly why we use antibiotics, sometimes for 3 to 6 months, to treat acne, and we'll get into that. So really, I would think of it as a hormonal issue that's activated the pilosebaceous gland, that's led to blockage of the hair follicles, and there's also bacteria that become involved because of the blockage, and they can cause more and more inflammation. Okay. Okay, so here's a nice slide that breaks it up a bit more. So the three factors causing acne development. So increased secretion of sebum, that oily substance from the sebaceous gland, and that's activated by hormones, right? So androgens and a bit, to a lesser extent, estrogens. The blocking of the hair follicles, right? So you have all these dead cells, increased keratinization, which blocks these hair follicles, leading to blocked skin pores. And then lastly, this bacteria that's called Propionibacterium acne, that's also involved in the development of acne. So the image below really will help, right? So on the left, you have stimulation of the sebaceous glands, and the second image, it's showing you blockages of the hair follicle from this sebum and dead skin cells within the hair follicle. And we call that a comedone, right? So that's just another name for a blackhead or a whitehead. Okay, so if it's oxidized and the comedone looks black, okay, well, that's a blackhead, right? So that's the early formation. And then the inflammatory phase. So now you're developing papules and pustules. So there's now bacteria involved, and the lesions are larger, so they're papular, and they're filled with some pus and some bacteria. And lastly, as they get larger, we call them nodules and cystic. And that's why there's a type of acne called nodulocystic acne, which is more severe than your typical acne. Okay, so the image on the left is showing you relatively mild acne, right? So if you remember the slide before, it's gone through that process of blocked follicles, leading to some inflammation, and that's why you see red lesions here. But it's relatively mild. Cystic acne, very different, right? So those small papules have become larger and larger and filled with bacteria and with pus, and we call that nodulocystic acne. That can happen on the face, it can happen on the shoulder, and on the back for patients. Okay, let's talk a bit about bacterial infections of the skin. So the first one we'll talk about is impetigo, Well, impetigo is a very superficial skin infection. Okay, so it's right on the surface. It doesn't go deep into the tissue at all. And typically it's caused by Staphylococcus or Streptococcus bacteria. And in actual fact, those bacteria can often be on the skin normally, just living there and not causing any problems at all. When they get overgrown or they colonize and start to multiply more and more, it can lead to impetigo. And impetigo is much more common in children. They kind of get closer to each other, they're hugging each other more, and this really spreads through schools, especially kindergarten and the earlier years in school. Okay. Now, poor hygiene can be a factor, but often it's not because it's quite contagious from child to child. Okay. So usually it requires avoiding of sharing of clothing, of towels, anything that can potentially spread the infection from one person's skin to the other. Okay? And typically, if you have impetigo, you're not able to go to school until it's completely cleared, because they know at the school that it's going to go from child to child to child. Usually, this is easily treated. Okay, so impetigo usually has this crusty lesion that we call honeycomb crusting. Kind of looks like dried on honey. And it's typically easily treated, this particular bacteria, whether it's staph or streptococcus, with topical antibiotics. Okay, and in particular, we use one called mupirocin. You might know it from the brand name called Bacterial. Okay, so we use soap and water to get all the crusting off, and then we apply mupirocin to treat the impetigo. Now, if the impetigo is severe, covering large sections of the body, sometimes we have to give the patient an oral antibiotic, such as cephalexin, okay, which is a cephalosporin. And because it's so widespread, we couldn't provide enough cream to get all the areas. So it just depends on the extent of the impetigo. Okay, the next bacterial skin infection, cellulitis, much more significant. Okay, this is not just a surface infection. This is an infection that's gone into the subcutaneous tissue. And typically, it's also caused by staph or strep bacteria. Okay, because that's often what's on your skin to begin with. And most of the time, there needs to be some kind of a portal of entry. So it could just be dry skin, or maybe someone has an open sore, or maybe they broke their skin from an abrasion, from falling off their bike. Whatever it is, they've broken the surface of the skin and allowed for strep or staph to enter. Okay? And then, of course, the bacteria spread under the skin in a condition that we call cellulitis. Now, can there be purulent drainage? Sure, maybe at the site of the sore, of the open wound, but not typically as the redness spreads under the skin. Okay, so the classic symptoms and signs of cellulitis, redness, and typically the redness is beaming. You can see in the image on the right. It's giving off lots and lots of heat. It's exquisitely tender. When you press someone's skin that has cellulitis, they definitely make a note to you that it's painful. Okay, so all the signs of inflammation that's caused by this bacterial infection that's subcutaneous. Okay, and if this were to spread or left untreated, it could definitely get into the bloodstream, leading to sepsis, and of course sepsis can lead to death.